Introduction of the speaker by Dr. Bean.
Good evening to all. I feel extremely happy to introduce Dr. Simi, our guest speaker. Simi, she's currently working as the Associate Professor in Department of Obstetrics and Gynecology, Government Medical College, Kannur. She passed MBBS from Thrissur Medical College and did her MD from Calicut Medical College and was the best outgoing student and with the gold medal. She secured DNP from the National Board, and she's a very good academician and a teacher for excellence. She has published many papers in national and international journals and is a member of the Medical Education PMC Kannur. And presently, she is the Secretary of Kannur and Society. Who is also an associate professor in Kannur Medical College, Kannur Government Medical College, Kannur, in the Department of Medicine, and they are blessed with 2 kids.
So I invite Dr. Simi to deliver the speech.
Respected seniors, colleagues, and my dear friends, a warm good evening to all. At the outset, let me thank the organizers of IMA Kannur branch, especially Dr. Beena, for giving this opportunity. And thank you, Dr. Beena, for the nice introduction. So today my topic is drugs in pregnancy, do's and don'ts. So before going to my topic, let me begin by sharing an experience. A few years back, when I was sitting in the antenatal OPD, a doctor patient came to me. She sat in front of me and she said, Doctor, I am 8 weeks pregnant, but I don't want to continue this pregnancy. So I was just wondering, because she's already 27 years, she's a primary gravida, and she's requesting for medical termination of pregnancy. So I asked her, why do you want to undergo termination? Because you're a primary gravida and no other complications you're having. Then she said, Doctor, for the last 2 to 3 months, I was regularly using a cream on my face for acne. And when I Googled few days back, I came to know that cream contains very high dose of vitamin A, and I found that it is highly teratogenic. So I don't want to have a baby with congenital malformation. I tried to reassure her that most of the creams used for acne contain very minute amount of vitamin A, and it may not be harm her baby. But she was not accepting it because she don't want to take the risk. So she opted for termination of pregnancy. So any drug, even the cream that we prescribe in pregnancy can be significant. So let me move to my topic. So whenever we prescribe a drug in pregnancy, we should ask ourselves, is the drug safe? Is it absolutely essential? For example, if a lady is coming with running nose and mild fever, is it necessary to prescribe antibiotics, or giving her some antihistamines and paracetamol, is it enough? Do the benefits outweigh the risk? Whenever we prescribe any drug, just see whether the risk is more or is the benefits are more. And is it being given for the shortest period of time? So why we are worried when we prescribe a drug in pregnancy? This is because of the teratogenicity. So the word teratogenicity, the teratos means monster, genesis means producing. So producing an abnormal baby, nobody wants to take that risk. So a teratogen means any agent that acts during embryonic or fetal development to produce a permanent alteration of the form or function of an organ. You call it as a teratogen. So a teratogen can be any tablet, the injection you take, the smoking you do, the cigarette, the alcohol, or even radiation. So any of this can act as a teratogen. But there are certain factors that affect the teratogenicity. One is the timing of exposure. This is the most important factor. So when we prescribe a medicine to a lady, other than the iron and calcium and folic acid, so at what time she is exposed to that medication? Is it in the first trimester? Is it in the second trimester? Or is it near the term? That is very important because some of the drugs may be harmful when she takes in the first trimester, but some other drugs will be harmful when she takes in the later part of the pregnancy. So the timing of exposure is very important. The second factor is the drug dose effect. At what dose the patient is taking the drug. Some of the drugs, when we take in very small amount, it will not do any harm. I remember when I was pregnant, in my 2 pregnancies, I had severe carpal tunnel syndrome. So I had to take 2 or 3 tablets of NSAIDs when the pain was very severe. But actually it doesn't do harm. But if you take NSAIDs around 30 to 34 weeks of pregnancy, that can affect the fetus. So the drug dose is also very important. At what dose you are taking the drug and how long you are taking the drug. And the third factor is the genotype of the conceptus. That means all the fetuses who are exposed to teratogens are not having any abnormality. Only certain fetus are genetically susceptible. So those fetus will develop the malformations. So these are the factors that affect the teratogenicity. Now let's see what are the importance of timing of the exposure. So we have, as you all know, the total duration of pregnancy is 40 weeks. So we can divide that 40 weeks into 3 stages. One is the germinal stage, that is from 0 to 2 weeks. That means at the time of fertilization or the formation of the conceptus till 2 weeks. That means by the time the patient misses her period, when she do the UPT and she comes to know she's pregnant. Second is the embryonic stage, that is 3 to 8 weeks. So when we say in terms of month, it will be roughly 2.5 months of pregnancy. Then comes the fetal stage from 9 weeks till birth. So what is the significance of this stage? Coming to the germinal stage, that is from the fertilization till she misses the period. During that period, it is like an all or none phenomenon. That means if the fetus, if that insult affect the fetus, that fetus will get aborted. That means miscarriage will happen. But if the fetus survives that insult, that baby will continue its growth without any problem, without any anomaly. So that is called all or none phenomenon. ഒന്നെങ്കിൽ അത് കുട്ടിയെ ബാധിച്ച് കുട്ടിക്ക് അത് അബോർഷൻ ആയിട്ട് പോകാം, ഇല്ലെങ്കിൽ അത് കുട്ടി അത് വിത്ത്സ്റ്റാൻഡ് ചെയ്യുകയാണെങ്കിൽ that pregnancy will continue uneventfully. That is the all or none phenomenon just before missing the periods. Now coming to the second stage, that is the embryonic stage. This is the most important period because all the organs in our body are formed during this embryonic period from 3 to 8 weeks. അതായത് periods നമ്മൾ just miss ചെയ്തു, pregnant ആണെന്ന് അറിഞ്ഞു, ഒരു 2-2.5 മാസം വരെയുള്ള സമയം. അപ്പോഴാണ് നമ്മുടെ central nervous system, the brain, the spinal cord, the heart, the eyes, ears, all the organs, the skeletal system, all the organs are developing. So any insult during this time can affect the formation of that organs, resulting in congenital malformation. Now, after that, from 9 weeks till birth, all the organs are already formed. Now they start growing and they start functioning. So if the patient is exposed to any teratogenic drugs, that can affect the functioning of that organ, or it can result in fetal growth restriction. So out of these 3 stages, 3 to 8 weeks or the first part of the first trimester is the most important period. So this picture again is showing the same thing. The upper part shows the graph. The light blue color shows the embryonic stage, and then you can see the dark shade, the embryonic stage, and then comes the fetal stage. Below you can see some red color. The red color shows that is the period of high sensitivity to teratogen. So you can see that each organs written there, the central nervous system, then the eye, ear, etc. The blue color is the time when the sensitivity to teratogen is very less. Now, the FDA has classified the drugs into various stages in pregnancy, depending upon the benefits and the risk. So category A means regarding this drugs, human studies have done, and the human studies shows no risk to that particular drug. That means that drugs are completely safe to administer in pregnancy. Examples are folic acid, the thyroxine tablets. So human studies are there, no risk identified. Category B means there are animal studies and the animal studies are okay, no side effects shown, but there are no human data to support that there is no risk. Examples are the paracetamol, then antibiotics like erythromycin, then commonly prescribed cephalosporins, penicillin group of drugs, all belong to category B. Then coming to category C. Category C means animal studies are there, but they are not okay. Side effects are seen when studies are conducted in animals. But there is no human data also. So the risk cannot be ruled out. You can take the medicine, but certain risks may be there. That's why we are seeing whenever we go through the pamphlets of certain tablets, they have the pharma company have written as category C. You have to, so many side effects they might have written. This is because the studies are shown only in the animals and that studies are not okay. That's why. So most of the NSAIDs we give, then drugs like opioids, morphine belong to category C. Then category D means there is positive evidence of risk. Actually, there is no animal data, no human data, but the benefits outweigh the risk. So we have to prescribe such medication to a pregnant lady because benefits are more when compared to the risk. For example, anti-epileptic drugs, antipsychotic drugs. Because if you don't prescribe anti-epileptic drugs, patient will go for seizures. That can affect the mother as well as the baby. And if you don't give antipsychotic to a patient, she will have mental problems. And if you consider the maternal mortality during the last 2 years, one of the most common cause of maternal mortality in Kerala was suicidal death. So actually it is very much alarming. So anti-epileptics and antipsychotic drugs we have to prescribe because benefits outweigh the risk. So usually after counseling the patient, we have to prescribe those medications. Then comes the last category, category X, which is contraindicated in pregnancy. So here the drug written is thalidomide, which we used to study in pharmacology, but nowadays nobody is using thalidomide. But drugs like statins, which is given for dyslipidemia, then drugs like vitamin A in high dose, all this belongs to methotrexate, all this belongs to category X, which we should not prescribe in pregnancy, and they are absolutely contraindicated. Now, a few words about the pharmacokinetics of drugs. What the drugs does in the body of a pregnant lady. Is there any difference when you administer a drug to a pregnant lady and when you administer a drug to a non-pregnant patient? Is there any difference in the pharmacokinetics? Yes, there are certain differences. One is the drug absorption. As you know, progesterone is the main hormone in pregnancy, and this progesterone will delay the gastric emptying. So it will take more time from the stomach to reach the intestine. So what happens? It takes more time for the drug to act. So when she takes a tablet, it takes more time to get absorbed and to get act. So for quicker onset of action, sometimes in pregnancy, tablets may not be effective. We may have to go for some parenteral medicine. Second thing is drug metabolism. The drug metabolism in pregnancy is also little fast because of the hepatic enzyme inducers. So again, the duration of action of the drug will be very low. The third point is drug excretion, because in pregnancy, the renal blood flow is more. So the glomerular filtration rate is also more. So when you prescribe some drugs, when the patient takes some drug, which is excreted through kidney, the excretion rate is very fast. So the drug will be acting only for a shorter period of time. Then comes the increased blood volume. So as you know, the pregnant lady's heart has to pump more blood because blood has to, for her body as well as for the fetus. So the blood volume will be increased. So when you prescribe some drugs, the concentration of the drug in the blood will be less because of the increased volume of distribution. So you have to make some adjustment of the drugs. For example, when you prescribe anti-epileptic drugs, sometimes we have to increase the dose of the drug little more when in pregnancy. So these are the pharmacokinetics. Okay. Now, instead of saying theory, let us move more towards some scenarios. These are some common scenarios which we'll be seeing in our daily day-to-day practice. Maybe patient will be coming to the general practitioners or gynecologists or physicians. I have selected some simple scenarios. So first scenario, a 35-year-old G2P1L1, that means second gravida, last childbirth 12 years back. Now she is 6 weeks pregnant. She's already a case of chronic hypertension and she's on enalapril 5 milligram daily. So can she continue enalapril or any change in the drug is needed? Okay. So we have to stop AC inhibitor. We should stop it, switch over to another antihypertensive. So we have a lot of options in pregnancy. You can go for alpha-methyl dopa, which is a safer drug, but unfortunately, alpha-methyl dopa is not available in our place now. Or you can go for nifedipine, which is a calcium channel blocker, or you can start labetalol, a combined alpha-beta blocker, which is a drug of choice nowadays. So why you are not giving AC inhibitors? Because AC inhibitors and angiotensin receptor blockers, they're absolutely contraindicated, especially in second and third trimester, because it can lead to fetal renal failure. So what will happen? No urine production will be there. The fluid, amniotic fluid will be very much reduced or absent. So baby will be having postural deformities. The contractures will develop. Baby will have postural deformities. So AC inhibitors should not be prescribed, especially in second and third trimester. So it is safe to stop if she is on AC inhibitor and switch over to some other antihypertensive. Now, moving to the second scenario, she is a 23-year-old primary gravida, 8 weeks of gestation, and she is complaining of fever, dysuria, and lower abdominal pain. The urine microscopy shows 40 to 45 pulses. So we all know suggestive of UTI in the first trimester. So anyway, we have to start an antibiotic. We can send for culture and sensitivity, but we can't wait for 3 days till the report comes because it's severe infection. She's symptomatic. We have to start the antibiotic. So which antibiotic to be started? So UTI in pregnancy, the drug of choice is always cephalosporins. Either you can start with cephalexin or cefixime can be given, or you can go for the penicillin derivatives. Either amoxicillin is also a good option. But nowadays, we the gynecologists, we prefer nitrofurantoin more nowadays because it is very highly effective. Because when you give cefixime and we have found the bacterial rate is still persisting. But when we give nitrofurantoin, maybe we are not routinely using that drug in the general population, we found to be more effective. But make sure, even though nitrofurantoin is a good option in the second and early third trimester, it is better to avoid after 36 weeks of pregnancy because it can lead to hemolytic anemia in the newborn. So no problem if we prescribe nitrofurantoin, but better avoid when she's near term after 36 weeks. And also avoid the fluoroquinolones, the ciprofloxacin, norfloxacin, etc. You have to avoid, and also the aminoglycosides in pregnancy. Now, moving to the third scenario, a 26-year-old pregnant lady with acute sinusitis. So whenever a lady comes in the beginning, we may ask her to do some steam inhalation, give some paracetamol. But if she's not responding, anyway, we have to go for the antibiotic. So as we know, as we usually prescribe, penicillin group is a good choice and it is effective against group A and group B streptococcal infection. And we also know the combination, amoxicillin clavulanic acid combination is also highly effective for respiratory infection as well as for the acute sinusitis. But it should not be used after 36 weeks as it can cause neonatal necrotizing enterocolitis. The studies have shown that there is some association when patients came with leaking per vaginum with PPRN before 37 weeks to cover the spectrum of bacteria. Initially, amoxicillin clavulanic acid combination was given, but later found that when those ladies delivered the children, their babies were having necrotizing enterocolitis. So it was an association found. So now the recommendation is that better near term, don't give the combination of amoxicillin clavulanic acid. Second trimester and early part of third trimester, it's okay, no problem. Now, another common scenario, a 38-year-old pregnant lady, she's an overt diabetic and on oral hypoglycemic agent, which is commonly used, the TAP metformin, 500 milligram BD, the sugar is well controlled. So, can we continue with metformin? Yes, we can continue with metformin because metformin and glibenclamide are safe in pregnancy. But when we were undergraduate students in the pharmacology, we have studied the oral hypoglycemic agents are teratogenic. You should not prescribe in pregnancy. That was the thing which we were taught. I'm sure you might have all read like that. Oral hypoglycemic agents are contraindicated in pregnancy. But later on, especially when polycystic ovarian disease came, patients were prescribed metformin as an insulin sensitizer. And later on, metformin was continued throughout the pregnancy. No side effects were seen. The babies were also born uneventful. There were no congenital malformation. And studies are also there which proves metformin and glibenclamide are safe in pregnancy. But just remember, it has been only last maybe like 8 to 10 years that metformin have been started using. So there is no sufficient data for the long-term effects of oral hypoglycemic agents in babies. Till now, no side effects have been observed, but we don't know about the long-term effects. So the gold standard for the control of blood sugar in pregnancy is still the insulin. We can use either the regular insulin or the combination, or even the newer insulin, the Lispro, Aspart, and even the Lantus. The newer insulins can also be used in pregnancy. Now, another common scenario which usually we get phone calls from our students and from our colleagues, a 23-year-old primary gravida at 18 weeks pregnancy, she's having chickenpox, active lesions in her body, chickenpox rashes. So is it safe to start acyclovir? Because usually for the non-pregnant lady patients, whenever a rash begins, usually we start acyclovir as early as possible so that the patient may not go for complications. So is it safe to start acyclovir in pregnancy? Yes, it is safe to start acyclovir in pregnancy. Use of acyclovir does not increase the birth defects. But the problem is that whenever the patient have or develop varicella in pregnancy, especially during the 13 to 20 weeks time, the baby can have, very rarely, the baby can have a syndrome called congenital varicella syndrome, only 1 to 2%. Even if the mother is not having any varicella, in the general population, incidence of congenital malformation is 3%. That means out of 100 pregnant ladies, 3 babies can have some sort of anomaly. That is a universally acceptable thing. So if a lady is having congenital varicella or the chickenpox, there is a chance of 1 to 2% of developing congenital varicella syndrome, but it is very rare. Till now, we have not seen any babies born with congenital varicella syndrome. I also discussed with the pediatric colleagues, they also have not seen any congenital varicella syndrome. But theoretically, the risk is there. So whenever the patient comes to us, we will counsel them that there is a chance of risk for congenital varicella syndrome. Actually, there is no any absolute need for termination of pregnancy. If they can continue, they can continue, no problem. But towards the term, suppose at 38 weeks, mother is getting congenital chickenpox. It is better to delay the delivery at least by 1 week so that the baby will get the passive immunity from the mother. Otherwise, what will happen? The mother getting chickenpox within 1 or 2 days, if the baby delivers, baby can born with neonatal varicella with generalized rashes in the body. But there is no contraindication for acyclovir. You can start acyclovir. Otherwise, what will happen? A pregnant lady can develop the complications like viral encephalitis and bronchopneumonia, which is more harmful to the mother. Now, the next scenario, a 20-year-old primary gravida, now she's 8 weeks pregnant. She gives history of epilepsy since childhood and she's on phenytoin from childhood. So the question is, can we continue phenytoin or should we switch over to some other antiepileptics? We have seen many of the patients on phenytoin who are seizure-free for last many years. They can continue the phenytoin. There is no much issue. There is a chance for congenital malformation, which is very rarely seen. But if they are seizure-free, they can continue with phenytoin. But if we want to switch over to new anti-epileptics, if we switch over, the dose needs to be adjusted. And during this drug dosage adjustment time, sometimes the mother can develop seizure, which is more harmful to the mother and the baby. But nowadays, we are not seeing mother with phenytoin because many of the, even the pediatricians, when the child comes with seizures, they are usually starting the newer drugs like levetiracetam, the Levipil, which usually prescribed, and that is comparatively safer in pregnancy. So most of the antenatal patients coming to us are already on levetiracetam. So they are continuing levetiracetam. So actually no anti-epileptic drug is completely safe in pregnancy. So no anti-epileptic drug is completely safe in pregnancy. And most of the anti-epileptic drugs are associated with fetal malformations, especially phenytoin and sodium valproate. But the preferred drug means it is the one that best controls patient seizures. നമുക്ക് വേണ്ടത് seizures ഇല്ലാത്ത ഒരു പേഷ്യന്റിനെയാണ്. Because if the seizure develops during pregnancy, it will be causing more harm to the mother as well as for the baby. So here you can see a picture showing the fetal anticonvulsant syndrome, especially with phenytoin, the fetal head and neck syndrome, where the baby will be having microcephaly, hypertelorism, flat nasal bridge. Then baby can have mental retardation, digital hypoplasia, cleft lip, cleft palate, all these things. Even though they are theoretically explained, very rarely see. In the few points which we should keep in mind is monotherapy is usually better than drug combination. So instead of giving two anti-epileptic together, monotherapy will be better because side effects will be less. And all of them should receive folic acid supplementation, 5 milligram daily. So whenever we give an anti-epileptic drugs, we should tell them to continue folic acid tablets. And another thing which we have seen that we have seen many patients on phenytoin and sodium valproate, but all the babies are not developing congenital malformation. This is because certain babies can have genetically susceptible, like deficiency of the enzyme called epoxide hydrolase. So if that enzyme is deficient in that baby can have folic acid metabolism problems and can have congenital malformation. So it is always better to prescribe folic acid, even an epileptic patient preconceptionally also. Let them take folic acid daily at least 3 months prior to conception so that the neural tube defects can be prevented. The newer drugs, levetiracetam, gabapentin, and lamotrigine, they are comparatively safer to prescribe. Now, another scenario, a 20-year-old lady with missed periods. She has just missed the period. She found to be urine pregnancy test positive. In the past, she gives history of rheumatic heart disease. There is a prosthetic mitral valve and she is on warfarin. So can you continue warfarin in the first trimester? Because she's already on warfarin, she needs anticoagulation. She's having prosthetic valve. Can you continue warfarin in the first trimester? No, because warfarin can lead to warfarin embryopathy, which is absolutely contraindicated in the first trimester of pregnancy. So warfarin embryopathy, here you can see the fetus with nasal hypoplasia, skeletal abnormalities, short limbs and digits, stippled epiphysis. And the risk is maximum when you prescribe this warfarin during the first 6 to 12 weeks of pregnancy. Now, so what you can do, because she needs anticoagulation. So in the first trimester, you can switch over warfarin to heparin. What about the second and third trimester? In the second and third trimester, if the patient is highly prone for thrombosis, we can continue with warfarin in the second trimester. Warfarin can be taken if benefits outweigh the risk. Because developing deep vein thrombosis and complications of thrombosis, which is more risky, it is better to continue warfarin in the second and the first part of the third trimester. But last 2 to 4 weeks, we have to change over to heparin. Because once you give warfarin, the action will last for a long time. So suppose if she goes into labor and you are conducting the delivery or you are doing the cesarean section, there is more chance for the bleeding. So that's why we are changing over to heparin. So in this context, I would like to share one experience. I had a patient, a few years back, I had a patient. She was a primary gravida. At 8 weeks, she came to me with severe DVT. It was an unprovoked DVT in the first trimester, 8 weeks of pregnancy. Usually, the postpartum period, either the later part of the pregnancy or the postpartum period, there is more chance to develop DVT if there is immobilization and all. But this patient developed DVT at 8 weeks of pregnancy and it is unprovoked. She's an actively walking lady and not having any bed rest, but she developed DVT. So she came to the medical college. So we diagnosed it as DVT extending up to the iliac vein. We had a cardiology consultation. They started her on heparin. So she continued heparin. And then when she reached the second trimester, again cardiology consultation was going on regularly. The cardiologist suggested better to change over to warfarin because she is highly prone for thrombosis. So warfarin was started. But later on, from some other medical doctors in the same our profession, she came to know that warfarin is a drug which should not be taken during pregnancy. So she was totally confused why I was given warfarin. It is a drug which can cause embryopathy that will affect my fetus. So when she came to me and she discussed with me, so I tried to reassure her warfarin is a drug, it's an anticoagulant, and you are a patient who needs anticoagulation. Heparin may not be enough for you. So that's why doctor might have prescribed warfarin for you. But it was very difficult to convince her. Anyway, she continued the pregnancy with warfarin, and third trimester she was switched over to heparin. Now, coming to the vitamins part, which is very commonly prescribed, vitamins and minerals we usually prescribe to all pregnant ladies. The only clear teratogen is vitamin A, which in very high dose can lead to CNS and facial anomaly. So that's why when I started the talk, I shared that experience where the lady used the cream with treatment of acne. So avoid creams with isoretinoin for the treatment of acne in pregnancy. So most of the creams which we use for pimples, they contain isotretinoin, and we doesn't know how much concentration and how much we are applying on our face. And even there are case reports where even the topical application of vitamin A has resulted in congenital malformation. So it's always better to avoid creams with isotretinoin during the preconception period as well as during the pregnancy. Now, next scenario, a pregnant woman got a dog bite. Again, a common phone calls we get from the community medicine department and from our colleagues and all. Pregnant woman got a dog bite. So can she take rabies vaccine in pregnancy? Yes, she can take rabies vaccine in pregnancy. The rabies post-exposure prophylaxis is safe for use among pregnant and breastfeeding women. Suppose if it is category C, she needs immunoglobulin. Can she take immunoglobulin? Yes. Rabies immunoglobulin is also not a contraindication in pregnancy. So both rabies vaccine as well as immunoglobulin you can safely prescribe in pregnancy. Now moving on to the last scenario regarding the radiation exposure. So again, I would like to share one of my experience. In our medical college last year, a patient came, she was a second gravida, around 20 weeks pregnancy. So she was complaining of severe low backache for the last 1 month. It's a very common symptom in pregnancy. She was having low backache. And so the gynecologist asked her to apply some analgesic diclofenac gel, do some hot fermentation, but she was not relieving of the pain. So she always, whenever she comes for the consultation, she was complaining of back pain and pain both hip joint and her. So finally, we ordered for an ortho consultation. So the lady went to the ortho department. She consulted an orthopedician, but unfortunately, that junior doctor sitting in the OPD, that doctor, unknowingly or unknowingly, asked her to do an X-ray. Take an X-ray of the pelvic area and come back with the X-ray. So she took an X-ray because she want to have a diagnosis why she is having low backache. She took the X-ray, came back. X-ray was normal. Again, she was reassured. She continued the pregnancy. Everything was going on uneventful. And after a few months, she delivered. But unfortunately, that baby had anal atresia. So after taking X-ray before delivery, she came to know from her relatives that X-ray should not be taken during pregnancy. So she was always worried that whether something will happen to my baby, whether my baby will be born with some congenital malformation. But unfortunately, that baby was born with anal atresia. So the bystanders and the patient was very much like, they are very angry. And they said, because the doctor prescribed X-ray and I took the X-ray, that's why my baby had congenital malformation, baby had anal atresia. So they wanted to give some complaint against doctors. And anyway, she didn't want to do surgery from Kerala. They went to Mangalore, did surgery from Mangalore. Anal atresia was corrected. And then even when she came after from Mangalore for the review, she said the doctors in Mangalore also tried to convince her it was not because of the X-ray exposure the baby had anal atresia. It was like a spontaneous, means it was incidental. The baby had the congenital malformation. So let's see what the literature says. So here in this table, you can see the amount of radiation to the fetus from X-ray during pregnancy. Just see a plain chest X-ray. The dose of radiation affecting the baby, affecting the fetus is only 0.01 milligrade. If it is plain abdominal X-ray, only 1.4. If you go to the lumbar area, because usually pregnant ladies, if you take some plain lumbar spine X-ray, only 1.7. What about CT? Because CT contain more radiation exposure. CT head, it is 0.005, chest 0.06. When it comes to the CT abdomen, it is around 8 milligray, and CT pelvis maximum exposure is 25 milligray. Now read the sentence in the topmost part of the slide. Minimum 5 rads or 50 milligray is required to produce an effect on the fetus. That means even if the patient is having 2 or 3 chest X-ray or a X-ray of the pelvic area, lumbar spine, it will never do any harm to the fetus. But again, when we were students or when we were postgraduates also, when we say the history taking, it's always like that. No history of any radiation exposure in the first trimester. That was a routinely we say in the first trimester history when we take the history, and that is always in our mind. Whenever there is any radiation exposure or one chest X-ray, we advise them not to take the X-ray. But that is we know our patients. It's very difficult to convince that regarding these points and all. But it's always better to avoid radiation exposure. But if it is necessary, maybe we have to take the chest X-ray. And during the COVID times, when in Pariyaram Medical College, we had lot of complicated cases. And there were patients with COVID pneumonia, and many times we have to take chest X-ray to chest X-ray as well as sometimes CT also, CT chest, to rule out the COVID pneumonia and the other complications. So only minimum 5 rads is required to produce effect on the fetus. So what the guideline says, a single diagnostic procedure does not result in harmful fetal effects, because most of the diagnostic procedures, the exposure is less than 5 rads. The concern about possible effects of ionizing radiation exposure should not prevent medically indicated diagnostic X-ray procedures. So if you're suspecting some pneumonia, you can take X-ray, chest X-ray. And if the patient is worried, you can do the abdominal shielding also, no problem. Ultrasound and MRI are not associated with non-adverse fetal effects, because whenever the patient comes with placenta accreta, which is very commonly seen nowadays, sometimes we have to take MRI to see the extent of the placenta accreta or placenta accreta into the bladder and all. So we are taking MRI nowadays. Again, it is not having any adverse fetal effects. So to conclude, the take-home message: whatever be the drugs used in pregnancy, the benefits should outweigh the risk. The drugs should not be prescribed on flimsy grounds, but at the same time, the drugs should not be withheld if it is really indicated. And the drug should be used for the shortest period as far as possible. Thank you.
Thank you for the excellent and very informative talk on the usage of electricity, the topic of pharmacology.
regarding the anti-thyroid drugs, it's always better to stop the prophyl thyroid in the first trimester because the cardiovascular drugs is that you have the baby. But the prophyl thyroid, the prophyl is continuing throughout the pregnancy. So again, the second trimester, it is stop cardiovascular. And the first trimester, prophyl thyroid. Metronidazole is actually coming in category C. It is commercially safe to use in pregnancy. Then nowadays, when the patient comes to get vaginal infection, even we are using vaginal tablets also, which can be mentioned. Thyroxine can be used in category A.
Thank you, Dr. dysfunction because of something more than what I mean is that as Google, there's a lot of even said the drugs and the they will Google it and they will come like that. And we have another experience like this we are so probably any drug is that people will go and read about it. They are everything. It was very nice talk.
The same patient, but in between, she was not having problem with the area. She came in habitual. She was that's why we had everything done. So when she came in the second pregnancy, then she came to us. And second pregnancy also, that was OBG, but then she was a high candidate for trauma. She continued, we started her in her parent, and second trimester also she is little on to take part. She continued her parent and what was the second and third trimester, now the 40 she continued. She's not normal, usually she's not normal.
It's like you take the drug trials. Drug trials usually the pregnant ladies will not be involved in the drug trials, and the elderly patients also will not be involved in that. So actually speaking beyond the real data about the pregnancy that we are lacking. Actually, the pharmaceutical companies put that as a study or not. This time I share one is that we have patients who had anticonvulsant candidates which was on sadness, well and afterwards became pregnant. Fortunately, she had a successful delivery. The side effects of pregnancy was what I was saying. We are like, we don't know what to do. Nobody knows about the pregnancy. We have to get the service. So what I mean is that still we would have been that very newer to the problematic is not like after sending the work. So we are going to face the future. Probably we will learn your address.
It's not recommended to allow them to try to experiment on their body. Even like if she's having a and if she's like candidate for surgical management, we can go for surgical management, we can go for no problem surgery actually. Otherwise, we can start antibiotic, like surgical started, no contraindication. Secondly, immunosuppressants like azathioprine, cyclosporine, all these are not contraindicated. But immunosuppressants are the just contraindicated. I have no much experience regarding. I have appreciated all these for azathioprine, then patients on steroids and steroids, if you're taking giving high dose in the first trimester, there are case reports of baseline. But we have a lot of IT patients not taking like 21 tablets. And even for the fetal unconstituted, we are getting beta-lactone and dexamethasone, we are getting this crosses the placenta and can go damage. Short term, this is what 24 or 40 days.
Antithyroid is the best.
Better option the first time. Second and third time we change.
Excuse me, I'm doctor.
Excuse me. Why we are not giving the first trimester is that maybe because of the aspect. So that's why we are starting from the second trimester.
Hello. Can you hear me, doctor?
Your question.
Yes. Hello.
Pharmacokinetics.
Hello.
Do you want to say some few words?
Can you hear me? Doctor, can you hear me?
Before I start, I request my colleague and I take for giving us this program. So I request some of the we are making to follow products. Wherever possible,
Dr. Suresh, can you hear me? Can you hear me, Dr. Suresh? Excuse me. Dr. Suresh, can you hear me?
On behalf of the Kannur IMA, I extend our sincere thanks to Dr. Simi Kurian for her excellent and highly informative talk on drugs and pregnancy. Thank you, Doctor. ഇന്നത്തെ കാലാവസ്ഥയിൽ ഇവിടെ ഈ ഇത്രയധികം മെമ്പർമാരുണ്ടാവുന്ന പ്രതീക്ഷിച്ചതേയില്ല. മൊത്തം 33 പങ്കെടുത്തിട്ടുണ്ട്. എല്ലാവർക്കും പ്രത്യേകം നന്ദി. ഓൺലൈനിൽ ഇരിക്കുന്നതാണ് ഏറ്റവും കൂടുതൽ മെമ്പർ. 41 മെമ്പേഴ്സ് ഓൺലൈൻ ഉണ്ടായിരുന്നു. അപ്പൊ എല്ലാ മെമ്പർമാർക്കും നന്ദി. Our special thanks to Elma Pharmaceuticals also for sponsoring today's meeting. Thank you all.
Hello. Dr. Suresh, can you hear me?
जनगणमन अधिनायक जय हे भारत भाग्य विधाता वंदे